Thanks, Helen. I will just very briefly share screens, and this will be our first test to see whether everything's working. So, can you see that? Just a quick thumbs up from Nina probably would be helpful. That's
yes.
it. All right. So, thank you, Helen, for that introduction. I'm going to just set the scene a bit and introduce our wonderful panelists today. So this is about music therapy with children with acquired brain injury and their families in the UK. And I just wanted to just give you a few figures to sort of put things in context, really. So the reason why this is an important subject is because head injury, and this is specific to traumatic brain injury, actually, which is one of the types of acquired brain injury. Head injury is the most common cause of death and disability in people under the age of 40 in the UK. And each year, 1.4 million people attend emergency departments, and between a third and half of them are children aged under 15. And what we know from these fairly old figures now is that these figures were conservative at the time as well. So there are, and that's due to the coding issues in accident and emergency departments. Now, what does this mean for children and their families? Well, for many children, particularly ones with mild brain injury, physical recovery occurs, and they're able to return to their usual school and to their usual activities. One of the longer term consequences that we know about are the cognitive problems that often prevail and are unseen usually in the early stages and only become more apparent later on. And those affect all children and adults with acquired brain injury. There's a great deal of loss that the children and the families where the child has an acquired disability, a great deal of loss that occurs in the process of coming to terms with an altered identity and altered function. And as a consequence, relationships change and some go. And there's an altered outlook on the future for those children and their families. So acquired brain injury is not discriminating, okay? And so it can happen to anybody, really. And so therefore, a child who is, say, achieving very well at school and whose family has very high hopes for their future, those hopes may have to change and their expectations may have to change as a result of the acquired brain injury. There can often be difficulty for the families to understand and interpret the changes in behaviour that the child might be presenting with. And for the child and their family, there may be difficulties with social connection and belonging, and the child's identity changes as well. And this becomes a heightened issue during adolescence, where the formation of identity is particularly important. So our speakers today will be in this order, and we'll begin with Clare Rosscornes from Addenbrooke's Hospital, who will describe how music therapy works within the multidisciplinary team in an acute hospital setting. Followed by Clare, we'll hear from Elizabeth Nightingale from Chiltern Music Therapy, who will show us how music can be used to maximise engagement in paediatric neuro rehab and describe its impact on families. Then Rebecca O'Connor from the National Rehabilitation Hospital in Dublin will present on the use of music to facilitate assessment. Followed by, this would be followed by Jonathan Fever from Chronotherapies, who will focus on the use of music to inform brain injury education and family understanding. And lastly, Claire Wood from the Children's Trust will speak to us about how music is used in emotional adjustment and identity rehabilitation. We will have some time at the end for questions and answers, and I would encourage you to use the question and answer function so that we can get those collected for the end there, where we can hopefully answer all of your questions and have a live discussion. Okay, I'm going to stop sharing now. There it is. And hand over to Clare Rosscornes.
Thank you, Jonathan. Hello, everyone. I'm just going to share my screen. Okay. Okay, so I'm going to talk today about working at Addenbrooke's on the paediatric wards, and excuse me, I'm just putting my timer on so that I don't go over. So I'm going to talk today about working on the paediatric wards of Addenbrooke's Hospital within a multidisciplinary team, and looking particularly at children with acquired brain injury. So first of all, just to look at the setting. So it's the acute paediatric wards within this larger hospital. And the families are there really in the context of trauma, because they might be there following an accident or a diagnosis. So they might be away from home, they might be not having family being able to visit. So this is the context that I work in and that we work in within this multidisciplinary team. So it can be unpredictable for the families, but also unpredictable in terms of the sessions that I do, in that sometimes we might plan a session, but it might not happen because the child might be asleep, or they might be having a procedure, or they might have to go and have a scan, or part of the medical team might have to come and see them. So it's working within that setting really affects the way I do the sessions. I have to be quite adaptable in that sense of the sessions are planned, but they might not happen when they're meant to happen. It's the beginning of the neuro rehab journey for these families, and they don't really know the outcome at this stage. So that's really just setting the scene of where I work and the what it's like for the families there. So I work within this multidisciplinary team, and this is the team. It's not an exhaustive list, but this really covers the key other roles there. Today I'm going to focus mostly on how I work together with OT, speech and language, physio, and the play team. And I'm going to talk about a particular child and family to demonstrate how I do that. So this is just a quote that I came across, which really showed what we were doing, and the way that when you work together as a coordinated team, that you work towards a common set of goals, it has huge benefits for the families. And that's really what I'm trying to show today. So just an overview of the different areas that I think music covers, and really for the journey that the child is on a neuro rehab journey. You know, we've got the physical side with the physio, and how music can help and be part of that journey. Communication, that might be non-verbal to start with through the music, but then bringing in sounds and vocalizations. Psychosocial benefits are huge as well, in that sense of bonding for the families, and the cognitive area for that neuro rehab journey, for the pathways in the brain, all of that is covered, how music can be part of that, all these areas. So just focusing first on the physical side. So sometimes you can see here, this is a tilt table. It's something that the physios would use. So it was Emily would start flat on the table, and then they would position it at various degrees for her to build up muscle tone. And she would have to be in this table for certain times of the day, or for the physio session. we found that actually sometimes doing it with a purpose, so the purpose would be, we're going to have some music while you're using this, that worked quite well. It wasn't every time, but that was one of the ways that we worked together. We would also use small and larger instruments to develop fine and gross motor skills. So sometimes we would have, we would give Emily a shaker, but other times it was for her to reach and take the shaker, which she couldn't do initially. But this was to build up her use of, particularly trying to build up her right-hand side, as well as obviously keeping the left going as well. So it's very practical ways that you can imagine using music in this way, but the joy of doing it together. I really enjoy working with the team, and doing joint sessions to me is probably my favorite way of working, really. So in interactive songs, so we would do actions and model those actions for Emily. Mum would sometimes help her with the actions, and that just built up over time with what she was able to do. With the vocalizations, so this was encouraging Emily to really she did a lot of listening to the songs, but then sometimes she started to actually vocalize herself. And I'm going to show some video which will show this as well. The speech and language therapist talked about how doing the sessions together with music reduced the feeling of failure for those trying to communicate with Emily. And what she meant by that was that sometimes with a child with an acquired brain injury, it's very difficult, if they're not verbal initially, to know what they are understanding, and also if they are enjoying something or not, or trying to understand what they are trying to communicate. And that can be quite obviously quite difficult, and you want it to not be stressful at all for the child or for the family. And she found that doing music actually reduced that feeling of trying to communicate, because the communication happened through the music maybe more naturally than it does when in just trying to speak. We used her first language in songs. It was Lithuanian, and Mum taught me a song which we used in the sessions, which was great. I love learning songs in different languages, and we used that quite a lot with Emily, and she did seem to respond to that as well. We used her teddies, you can see in the picture, and it was just everything, just trying lots of different things, a lot of trial and error as well, but working together in that way. And Mum continued to do a lot of the movements with Emily during the week following this. So I'm going to show a video now. I'm going to stop sharing so I can bring it up on the screen. And in this video, you'll see some vocalization and the things I've talked about as well. I realise I'm out of time, so I'm just going to finish really quickly. I hope you can see lots of things happening in that video, and how Mum was so involved, and that she was a big part of these sessions as well. So just finishing off here with the setting, that was the room where we have the sessions, and just the medical staff, how they might sometimes hear the sessions, and that can be really important. So although that is the setting where you're going to have people coming in and out, but actually for them to hear that can be very helpful for them to see that bigger picture, or to see her enjoying an activity. The Onward journey, I know we're going to hear lots about other parts of the neuro rehab journey for a child. So that's what happens when they leave the hospital. And this is my conclusion of how I collaborate with my colleagues, but how it can really have huge benefits for the child and the family. So thank you very much. Sorry, the end was rushed.
Thank you very much, Claire. That was lovely. Okay, as we are going to save our questions for the end, I'd like to move on to Elizabeth. Hand over to her.
Hello. I'm just going to share my screen. Okay. Okay, so I'd like to discuss the unique role that music therapy plays in maximising engagement in paediatric neurorehabilitation, but also I'm going to be touching on the digital legacy from the COVID pandemic and some of the implications that's having as part of a mixed modality rehab model for children and young people with ABI, but all within the broader context of thinking about the unique impact of how music therapy plays an especially unique role in building relationships for families accessing music therapy. So I think we already are aware from kind of neuroscience research the impacts of music on the brain, that it stimulates more parts of the brain than anything else simultaneously, and we can use music in its the unique way in which it's processed to build these new neural pathways around those areas that are damaged by disease or injury. So I think that unique global activation that music has on the brain can really be capitalised on in rehab to give children and young people the best possible opportunity to respond and engage in their rehabilitation. I think particularly the strength-based approach of music therapy can provide valuable opportunities for family involvement in areas such as sharing musical preferences. Obviously, we just heard a nice example there of introducing kind of culturally meaningful, relevant music, that being a great way of being able to involve families as well. So we can tailor those interventions to really help maximise motivation as well. I think experiencing meaningful time together, using music and learning new ways to share that connection is another significant attribute from our input. And again, I think we saw a really beautiful example of that just now. I think working alongside families, but also more broadly those in their life, to kind of upskill and build their confidence to then share in their loved ones' rehab journeys through a therapy that can be both functional and fun, can be crucial as the family unit adapts to life after injury. So I would like to share a sort of short compilation of extracts from sessions with a 16-year-old with acquired brain injury and cerebral palsy. Her name is Julia, and videos and pictures are shared with the consent of her family. And Julia is also non-verbal, and she is a wheelchair user as well. She was first assessed by me in 2019, and the reasons for referral initially came through from her case manager around opportunities for self-expression, pleasure and enjoyment. She'd actually had quite a traumatic experience in a residential facility prior to us getting involved, so it was very much felt that those immediate psychosocial needs for the family and bonding were really, really important. But what emerged through the process of the assessment was all of these other areas that music could help support with, both psychosocially but also functionally as well. So some of our sort of broader sort of therapy aims ongoing were centred kind of around the communication and cognitive domains. So we were looking at things like choice making for activities of daily living, so working on those choice making skills, initially using eye pointing and then later interweaving some eye gaze technology as well. Working on non-verbal social skills, consistent use of a switch, and developing use of her left arm that we could work towards with occupational therapy towards her driving her wheelchair. So lots of different kind of ways that we were working together. And each of these goals sort of had a related SMART goal and NMT technique that we used as part of her rehab as well. Other broader recommendations we had were on ensuring that collaborative approach to goal setting, particularly with speech and language and OT, and supporting opportunities for shared interaction and functional carryover. And to that end, we implemented a home programme and some staff training, as well as family training sessions to support with this. Sort of that general implementation. So let's take a little look at some clips, and then I'm going to speak after about the digital parts that we can see in action here. I think it's really in the seeing and the listening that we can kind of grasp that wider impact on the family. This little Julia, press the switch. Ready, go! We're playing here with music.
I think it's a big thing, music, with me and Julia. She likes music, and I like it as well, and we sort of that connection there straight away. I've always known that she could do it if she's pushed in the right direction. I just knew since she was born, really. When you tell others, they don't believe you, but I knew there was something there we could get, and we're getting it. I've known since she was born, really. I knew that, even though her condition, I knew there was something there, and only one person said the same as I have, and all along I've said we can get as much as we can out of her, and here we are today. We're getting quite a bit. The music's the one what brings all the activities, what she does during the week together in a very musical way, and she likes all that. She's come along really well with her school as well, so I think that helps as well, and with the music it just enhances it, I think. No, I just think everyone should try it, everyone should go for it. You've got to give it a try, and I'll guarantee you'll like the ending results.
So something Mick touches on there, Julia's dad, is on how music therapy really brings everything that she does in the week together. And I think this is another really unique strength of our discipline, our crossover across all of those different functional domains and therapies into that one integrated experience. And I think that's so important, particularly when we're thinking of supporting families to continue with that rehab at home, back home in the community, keeping motivated with that, rather than perhaps giving a young person several different things to be doing on a given day, which is exhausting for them and for the family as well, thinking how we can really be integrating those into one experience. And I know myself, I've done a lot of collaborative working with the team, looking at how we can incorporate various functional goals from the different disciplines into one integrated music therapy exercise or activity that we can use. So you'll have noticed, of course, some of the extracts that we saw there were digital. And during the pandemic, we did have a long stretch of sessions being online. But I think what was really encouraging during this period was that between digital NMT and the other digital solutions that we sought to make available, we were still able to find creative ways to continue supporting with her therapy goals. And amazingly, she actually remained on track with all of these despite accessing that online provision. And it also kind of afforded a brilliant opportunity to kind of do more focused training with family and support workers working with Julia as well to carry ideas forward with her throughout the week. So I think whilst technology featured as a regular tool for some practitioners before the COVID pandemic, I think the increased need for digital provision resulting from various lockdown periods required us as music therapists to kind of radically innovate and adapt our practice to online platforms and to further embrace the clinical possibilities available through technology. So live digital sessions enabled some consistency for our children and young people during a time of great change and uncertainty, and also afforded a level of meaningful interaction, though of course issues such as latency and difficulties attending to the screen challenged us all to kind of collaborate more closely with clients and families to identify perhaps a myriad of solutions that could supplement that therapy work together. So some of those that the kind of key ones that emerged were kind of pre-recorded content for the clients to engage with directly, demonstration training videos for family targeted at sharing expertise and upskilling those working with children and young people to then carry forward an exercise, approach or a strategy live with them at home. Audio content including playlists to support mood and or original songs to support with areas including bedtime routines and activities of daily living. and home programmes and tailored activity packs that featured techniques and strategies that family members and support workers could use at home to support those functional goals, but also, of course, emotional well-being and mental health during a very uncertain time. And I think these digital resources became especially important for clients and families who wanted to continue supporting with their child's neuro rehab at home, as well as have access to stimulating activities and exercises throughout the week. I was chatting actually with Julia's case manager today, and one of the things that she remarked on was how much Mick would look forward to our digital sessions, which were on Fridays at the end of the week, particularly during those lockdown periods. There were very few of her therapies that were able to transfer online, and those that did were not consistently each week. So there was really something unique that music therapy was able to step up and do across the team in that instance. So Chiltern carried out a research project during the pandemic that focused on analysing and measuring the similarities and differences between in-person and digital music therapy provision from the client perspective. So what did we learn? Well, clients really missed the spontaneity and closeness of in-human interaction. So we're not out of a job yet, which is good, but I think regardless of all this, they did express that for many, they felt the relationship was unchanged with the provision, and if anything had helped to build a closer working relationship, particularly with carers and parents that were perhaps not always part of in-person sessions. So I think this had some really valuable implications for paediatric work and rehab, where we really want to be upskilling those working directly with our children and young people, sharing our expertise so they feel confident to support in their ongoing rehab where this feels appropriate, of course. So whilst there were definitely barriers and limitations that we were able to identify, some key benefits of digital provision, according to our clients, included accessibility, so content made available for them throughout the week. Consistency, as access to therapy didn't have to stop, and flexibility to access sessions and additional digital resources according to their own timetable. And when I think about the potential rigidity of some clients' therapy schedules pre-pandemic and issues such as fatigue management, I think digital resources can really serve a meaningful additional solution when provided in balance with that sort of direct session support. And that sort of mixed modal approach to therapy is very much something I've continued to explore with Julia to that effect. So in conclusion, I'd say the pandemic sort of forced our profession to innovate and find creative solutions to support our children and young people to continue accessing music therapy interventions through our online platforms. And from the range of digital adaptations explored by our therapists and clients and the ongoing research and development exploring a mixed modality rehab model, I think the digital legacy and implications for paediatric neuro rehab look particularly exciting. And assuming that we're all agreed in wanting to keep our clients and families at the heart of the work, the scope of potential impact of music therapy in shaping, supporting and developing the family unit only looks set to increase, and we can all play a unique role as part of that journey. Thank you.
Thank you very much, Elizabeth. And the next person to speak will be Rebecca O'Connor. We'll hand over to her straight away.
Hello, thank you very much. Just going to share my screen here. Hi, okay, so I'm going to be talking about the use of music specifically in assessment. I work in a rehabilitation unit within a rehabilitation hospital for children who have had complex brain injuries and spinal cord injuries. And the use of music in assessment has kind of evolved over the years while I've been working there for the past 15 years. And I'm doing a lot of the work that we do is interdisciplinary with members of the interdisciplinary team. And this, what I'm talking about today, is particularly about interdisciplinary work that I've developed with a neuropsychologist, a fantastic neuropsychologist, Dr. Sarah ODoherty, who shared with me writing this presentation. So the reason that we use music in assessment, as I'm sure you all know, is the concept that it engages the neural networks shared with all of the non-musical elements of the brain. So we're looking at cognitive, motor, emotional, and language functions. And the more children that we began to see together, myself and Sarah, the more we realized, and Sarah specifically realized as a neuropsychologist, that she could see rich data and information about these very difficult to complex children who are so hard to assess through just by observing the musical interactions. So we discovered that we could actually gain all of this information. She would be able to observe the musical interaction in a music therapy session. And so we started to develop and formalize this over the past 12 years. We called it the OOMPA. She came up with that fantastic name, the OConnor Idolity Music Therapy Psychology Assessment Method. And this is something that we've been developing for 12 years, where we're really looking at the child's strengths and trying to capture their abilities rather than what they can't do. And the impact that the OOMPA has is really on the team and on family members is extraordinary, in that they can look at their child as their best in musical interaction. So the OOMPA is an observation-based assessment method, which we developed combining over 50 years of joint clinical experience. We were a bit surprised when we added that up. The information can be used to help focus treatment plans and maximize available therapeutic and financial resources, and also in helping parents and interdisciplinary team within the hospital and post-discharge in planning treatment resources. As I said before, it's carried out jointly by the psychologist and music therapist. So Sarah, or the psychologist, will sit in the corner of the room. She is non-participant, and she is observing and scoring what she is seeing. And it's almost as if I'm creating sort of a musical Petri dish, so to speak, creating all of these different interactions and offering these opportunities for Sarah to see, and for the family members who are all present in the sessions, the mum and the dad, where appropriate, where they can see their child interacting. It's for children between 6 months and 18 years, and we use a series of music-based scenarios which provide key information, which is, I need to stress, this is part of IDT evaluation. It doesn't stand alone. So we have our test manual, which incorporates the score sheet, quite a detailed score sheet, which is added to a report template. So the reason that we are finding over the past 12 years, we've been using this increasingly with children in the unit, is that it describes their strengths, as I said before, in relation to key functions and specific developmental skills. So we're looking at things like readiness for therapy, timing of therapeutic interventions. Sometimes it's too soon at post-injury for a child to come. So what we said we might do is myself and Sarah will be invited to go to the local paediatric hospital, and we'll do an OOMPA assessment to see if the child is ready to be admitted to the rehabilitation unit, where they only really get one shot of rehab. When is the best time for that? We can then assist with goal setting within the interdisciplinary team. It also can be used for a baseline against which to measure future change. We've done this for a number of children who've been coming back over the past 10 years, and every time they come in, we do the OOMPA protocol again, and we do have video recording so we can analyze it, and it helps measure the efficacy of therapeutic interventions through this repeat assessment. So as I said before, it's got the nine items within the protocol. As you can see there, we look at them from the second they walk into the room to the second they leave the room. And then there are these quite specific structured activities that I do with the child, and Sarah scores. So we're looking about things like orientation, awareness of time and place, attention, concentration, capacity for new learning. We use music to look at memory, visual, verbal, working memory, recall. So we will, if we see a child through repeated sessions, we might introduce a specifically composed song in session 1, and then we'll see if there's any recall or recognition or long-term memory from the same song. We also look at processing speed, executive functions, social skills, a whole range of behaviours. And the more we do this and the more we evolve it, the more we and the team are saying, oh, can you look at that? Can you look at that? So it's quite taken 12 years to evolve this because we are seeing so much within this rich musical environment. So, and recently what we're doing at the moment is we're trying to see children in the first week of their rehab, and they'll stay for 12 weeks, and then we might do the UMPR in week 6 and just before discharge, and we'll have the SLT and the OT will also observe the session, or we will show them videos of the session. So this, I think it's best really to show you how this works. So this is item 4, which is musical improvisation. And I have a video example of this with a little girl who had a profound brain injury aged 3 months. And she was left with a cortical visual impairment, severe cognitive disability, and language and communication difficulties, and weakness of her left side. So we're looking at, there's a specific focus on attention within our musical improvisation protocol. We're looking at the deduction. Is she able to, does she realize the music is connected to her? Is she able to concentrate for the length of the music? Can she cope with the novelty? Sometimes these kids, this is the first time they've seen me or a flute or the music therapy room. Looking at cognitive flexibility, and can she localize to? So I want to just briefly talk about another aspect of the protocol, which is the familiar song, which is something that we bring in specifically to focus on memory. So we talk to the parents beforehand, saying what is their favorite song, what is a song that you have seen them respond to. So we're looking at recognition memory. Can they recognize the song, recall memory, their ability to have cognitive flexibility. So I will play, as I'm playing the song, I will bend it and stretch it and mix it and match it to according to the child's movements and vocal sounds. So can they realize that the song is connected to them? Sense of anticipation and building up that sustained attention through anticipation and musical anticipation, shared engagement. We're looking at all those lovely communication skills, you know, pre-verbally turn taking, and specifically emotional response. Often with a familiar song, you can see this emotional response. So you can see the aha moment of recognizing. So this is a little boy who had an underlying rare genetic disorder, who had complex physical and intellectual difficulties before he had his left-sided stroke. So he was diagnosed with severe intellectual disability, and he'd undergone a number of cognitive and neuropsych assessment tools, which were just not telling anything about his strengths and what he could do, because he was such a highly sociable child. He was one of our favorites within the team, and there was a query whether his ability was stronger than indicated by previous assessments, and because of his social skills, were we able to tap into his social connectivity to see what he really could do. So just to conclude, the UMPR, as I said, has been developed over 12 years, and it's taking much longer than we had hoped, because we just keep developing all of these new ideas. But it is recognised as a unique and valuable assessment method for the IDT, and also to inform parents. And we're increasingly being asked to go to hospitals across the country to do this pre-admission to rehabilitation hospital. It's now part of IDT assessment in our unit. And like I said before, it's focusing on the strengths. We get a lot of positive feedbacks from parents to see their child at their most interactive. And we're running our first training course with therapists in Dublin this year, planning for it to be available in the near future. So thank you very much for listening. I'll hand back over to you now, Jonathan.
Thank you, Becky. Okay, let's hand over to John.
Thank you. I will just share my screen. Okay. Good. Right, so I'm just reading my clock. So before we get started, sorry, excuse me, I just wanted to reflect on how much my presentation will just call back on a lot of the things you've just heard in some ways. Thinking about maybe approaching a number of the assessments or interventions just with a slightly different mindset. So I'm thinking very specifically about that brain injury education and family understanding. And it's just think it's really important to really change our viewpoint sometimes to develop a bit more of that upskilling that Elizabeth was talking about earlier on, from the family and carers and otherwise, as we may only be seeing these young people maybe once or twice a week if we're lucky. So initially, I'm just going to talk a little bit about my the environment the environments in which we might be working in. So we could be working within acute settings, as you've seen from Claire. There's post-acute rehab settings that Rebecca was talking about in the community, Elizabeth was talking about, and also then in care and education settings, in a variety of different inpatient units or otherwise. So for me, I work predominantly in an acute hospital setting, similar to Claire, so it's a paediatric hospital. And just to give you a quick overview, these are patients who are medically unstable, so they may still have physical injuries to recover from. They may be balancing medication, they may be highly dependent on oxygen, maybe. They may also have ongoing surgical intervention that may well support their ongoing recovery. Or it may well be that those surgical interventions can cause secondary injury. So we're not always looking necessarily at continuously an incline in ability. We could be looking at a plateau, we could be looking at a decline. We're just keeping an awareness of where we're at with these children when we are giving that education to those families and to those carers who are with us. So just to talk a little bit about the common parental experience. So how are they approaching us? Where are they coming from? Who are we talking to? Who are we educating? So these are our families, parents, carers, extended families, depending on who's in with the child at any one time. And they are really experiencing something very different, something very new. The child's presenting very differently. They've had an acquired brain injury. They're not presenting as they have done previously. They have grief associated with this. And that obviously brings up a lot of complications in a sense of when we are working with the families, with the children, particularly if we are talking about difficult subject matters and educating them on what may have happened during those situations, during the injury and otherwise. They're experiencing new roles. So we have these families who are maybe for the first time experiencing different kinds of transferences, different kinds of ways of being and interacting with professionals in a way that they haven't done before. So they're losing confidence maybe. They may well be hoping for us to fix everything, hoping for us to be able to communicate to their child in a way they never have done, or it may well just be triggering for them in lots of different ways. And also it's a very new environment, an environment that's quite difficult for a number of reasons, being in a hospital, clinical, medical environment. So we have the NICE guidelines giving us a very brief overview of what they hope that we might be able to do when we're communicating and educating family and carers about brain injury. This is just taken straight from their website, easy to find online. Just a quick overview. First section, I think, is just about really us introducing ourselves clearly and providing clear access to information, considering by what means we might share that information, promoting family engagement and participation, and again, how we might share that information. But for me, my hopes when I'm approaching and within our team, what we might hope to do when approaching brain injury education with parents and families is to really drive home these kind of main points. So, I mean, what is a brain injury? What does it mean to have a brain injury? It's not something we normally think about, and not something that hopefully we have to think about. What is it that's changed? What are the implications of this particular brain injury? Because every brain injury is different. Everyone experiences them differently and responds in a different way. Talking again, like the NICE guidelines said, who are we? Who are these professionals that they're now coming into contact with? Who are music therapists? It's always a good one to discuss. What exactly are we observing? What are we looking for when we're in the room? What will we be doing to support their progress? And what might that progress be? So where might we be aiming for with their child? So it's really useful to think about those SMART goals and things and aims that we might be working towards. And specifically for me, what I think is really important within my work is that sense of bringing connection and togetherness in the room. Just very helpful in a sense of normalizing the situation for all of us. So within the acute hospital setting, there's already a number of strategies in place to help parents and families to learn about brain injury and to learn about what they might be coming up against, or what they might need to do, what their roles might be. So some of those are consultants, for example, the medical team, nursing teams, thinking of daily cares on a daily basis, psychology team, maybe working closely with the music therapy team, and the therapy team themselves. Within our group, within our setting, we have a key worker allocated to each family, and they are there to liaise with the family to support them with their understanding of the offer of rehabilitation. So that's about the 24-hour timetable, maybe, goal setting, assessments, meetings, and to help them to access information and materials. But particularly, they might be looking at sessional education, so within each session, which is more about what I want to kind of go on to, thinking about how music therapy might help with our education. So within our sessions, what I think, I'm just taking this next section just to break down a few a few thoughts and certainly theories and approaches or ways of being really in the space to help us to interact and help us to build on that education. So modeling and reflecting. So I think within music therapy, within our work, we can really present a new way of looking and observing their child in play, just as Rebecca was saying within her assessment, that sense of showing people how playful interaction and musical interaction particularly really helps to prime the brain and really helps to prepare someone for rehabilitation or ongoing development. It's not just about playing, and it's not just about listening. There's much more than that. It's much more that we may be observing or considering when we approach that. And it's not even necessarily about new ways of acting around the child that we might be trying to model for the adult, but also a way of approaching or a way of reflecting after doing so. So Matadoc is actually a really good example of this. So we introduce baseline observations, pre and post stimulation. So within the Matadoc assessment, this is modeled elsewhere on therapy timetables, but it's really important to highlight this as much as possible, particularly working in a disorder of consciousness setting or a child with a disorder of consciousness. And there's really, I found there's no better way to do it than to model being still and looking while being surrounded by noisy things, lots of different noisy objects and instruments. And we watch first and then present our sensory stimulation. Often in conversation or interaction, it can be very difficult for parents not to fill that space or to support or to answer in the place of the child. So we're really looking for the child to listen and respond, and it's easier to introduce the way of listening and the way of being within the music therapy space by using musical modes, by using musical devices. Just to really support that sense of allowing time for processing and allowing time for the child to respond with any behaviors or any particular movements that we might be looking for. And thinking of how it's quite a familiar space. So music as a performance is a space where you would sit and you would listen and you would watch. And that can be really supportive and in the sense of the structure and the space, the flow, the timing, and the harmony or dissonance and fragmentation, depending on the stimulation offered. But overall, that sensory perception through artistic modalities is this. It's quite a common thing that we might be discussing outside of a hospital setting, outside of a clinical setting. We often talk about how amazing that gig was last night, or what did that sound like? This new song that's out, we really think about how it affects us emotionally, how it sounded, how it made us want to move. And it's much easier to actually to break down how we access child's abilities and hopes through musical conversation. Additionally, I'd like to think about how responsive and inclusive music is. So we are much more often than not, as a music therapist, we're facilitators rather than fixers. So parents will always know more about their child than I ever will. And their voice is from research is something that's always going to be much more motivating than mine. So it's really lovely to see all these examples of parents being highly involved in what's happening in the care. It's also very connecting. There's music in the room, we're all listening and we're sharing in it together, so we can share in that experience. And it really helps to just build that engagement and motivation of that shared musical interaction, shared musical listening, and helping us to reconnect with our roles and empower parents. And also promoting emotion in a medicalized environment for parents' benefit, reconnecting relationships, supporting people to be to kind of be themselves, but to reconnect with their child, but also thinking about how those emotions, that affect, helps that neurological priming and helps them to facilitate or find connections, should we say, in the brain through indirect but functioning pathways in a broken system. And at times this can really offer a real glimmer of consciousness through a lovely moment of affect, which is very useful. So those are just some real general overviews, and hopefully to spark discussion later on and thoughts. So just to return to this list of hopes, I think this is really the crux of it for me. What is it that we do when we're approaching working with these children and families, and how do we really maintain not only the focus on the child but a wider context, and how we can upskill those parents and families? It'll be interesting to hear how the rest of the presenters do this too. Okay.
Okay, thanks very much, John. Okay, our last presenter is Clare Wood from the Children's Trust. I'll just hand over to Clare.
Hi, everyone. Okay. So I'm Clare. I lead music therapy in the Neuro Rehab service at the Children's Trust here in the UK. So children and young people who have a severe ABI come to us for intensive inpatient neuro rehabilitation, quite often actually after they've been in acute hospital with either John or Claire. And whilst we support children with all their rehab goals in the music therapy team, it's their emotional adjustment and changing identity that I'll discuss tonight. So Neuro Rehab seeks to enable survivors of brain injury to make the best recovery possible and adapt to their changed circumstances. Psychological adaptation is arguably, however, the most crucial element of optimizing recovery in the longer term. Music therapists have long recognised the role that music therapy can play in identity work with adult brain injury survivors. Tamplin and Baker have even developed a 12-session songwriting protocol to overtly address the integration of the former and current sense of self. Baker, Kennelly and Tamplin have also written about songwriting with children and young people following traumatic brain injury, and of how adjustment involves the formation of an identity that integrates all aspects of the self. Predominantly, the music therapy literature is geared towards identity work with adult survivors who had, of course, an established identity prior to their ABI. And children and young people haven't reached maturity yet and don't have that established sense of identity. And that, of course, impacts the process of identity rehab. So for children and young people, their sense of self is dependent upon their individual story and also very much upon their age, as identity formation continues throughout childhood and adolescence. Sense of self can also shift within different contexts, as it can depend in part on who is around the child to offer acceptance, or sometimes, and painfully, rejection. With the very youngest children, a sense of self is intrinsically linked to the reflection of themselves absorbed from their parents. In music therapy, in the music therapy room, we might literally see children sing, play or dance and turn to their parent to check in for a smile, an affirmation that I can do this, and so absorbing the self-concept, I am okay. Therefore, as we've seen several times tonight illustrated beautifully, supporting the family who nurture the child is absolutely crucial, and especially so for the very youngest children. And often we work with families taking part in the therapy. And music is just such a gift of a resource to us here, as music holds cultural and spiritual value and can help to affirm the identity of the whole family unit, the whole family system, found to be a key factor in supporting family resilience and improving outcomes for children. Helen Schumark, in her team's review of a music therapy service in a children's hospital setting, reflects that a patient's musical heritage might be relegated to the background as preparation or assessment, and yet it's clear that musical heritage provides a link to individual and family identity and should be brought right to the foreground in identity rehabilitation. So when a developing identity of a child or young person has been disrupted by an ABI, what might identity rehab look like in the music therapy room? So where I work, I've seen the themes of identity, of who was I, who am I, who will I be, emerge in various ways, both overtly and more covertly too. For example, chatting around returning to instruments that they had some mastery over previously, considering what they used to do and what they can do now, even asking questions about whether they will ever play in the same way again. And also less overtly, identity issues may arise through their choice of songs, often shown to be significant to children and young people because they return to them again and again. Of course, after an ABI, children might become quite perseverative, and generating new ideas can be particularly difficult, but the emotional significance of these songs they return to can be really sensed through change in posture or how they sing or how they listen, their quality of attention. I've then often explored these songs further, sometimes by changing lyrics to be even more personalized, and it's evolved into songwriting about themselves, not always their life story or feelings, but always affirming who they are in some way, which often makes them smile, maybe mentioning what they're good at, who is most important to them, or even who their favorite animal or type of food is, things that have helped define them in some way in the past and continue now. And I found it really helpful to consider my work within the evolving identity rehab model developed by clinical psychologist Dr. Alison Perkins, who also works at the Children's Trust. She's generously shared her wisdom with me in clinical supervision and also some slides today. So this shows her overarching framework that she's developed. And Alison suggests that different modalities of identity work, whether it's psychology-led narrative therapy, play therapy, or music therapy, fit into this. So each level goes into greater depth or explores identity more directly, from establishing safety at the base up to ways of integrating information about the injury to consider how will life be now. Children and young people need the affirmation of that grounding base level, described here as addressing foundational chaos, before being able to move to other levels, and they can then move between these higher levels, both up and down at their pace. I've become increasingly aware of the unique role music therapy can play within the interprofessional team. In particular, as also noted by music therapist Janine Bauer, music therapy offers something unique for young people who have post-traumatic amnesia or PTA, in which they might experience really highly distressing levels of disorientation. So I'll share a case study now to illustrate identity rehab in music therapy alongside the evolving identity rehab model. So my case study is of a young person in the early years of senior school who had an acquired brain injury following cardiac arrest. His disorientation was exacerbated by cortical visual impairment, and he presented as perpetually going into phases of distress, not knowing what was real or where he was. And we began by singing simple call and response based on a familiar melody. And it did bring some moments of relief, little moments of connection, like little floating islands within the chaos. And we built upon this by singing an orientation script. So a script developed with his family and psychologist, reminding him of his name, that this was real, who we all were surrounding him, and that very much the most important thing, that we were there to help him. And I set this to music, and the young person began to remember the melody and with it the lyrics, and he would join in from session to session. And it felt like we had a bit stronger sense of solid ground now, so a deeper foundation. And the momentum continued to build as we worked together and as he emerged from PTA. And he brought a tremendous sense of humour and a great, loud, resonant singing voice. He also had an extraordinary gift for making percussive beatboxing sounds, which we'd listened to together in some of his favourite songs. He was really pleased that I was less gifted at doing the beatboxing, I should say. And I could reflect on his strengths, his humour and his musical talent, because this had been such a positive part of his identity pre-injury, and now could be a part of his present and his future. I think also that for somebody who's been in PTA, from moments that he could remember, having experienced such chaos and distress, it's hugely significant for him to again feel likable and fun to be around. And the links between who he had been and who he was now provided that sort of thread of continuity, that continuous sense of self, which we seek to support ABI survivors with in identity rehab. So Tamplin and Baker placed this at the centre of their 12-session protocol for adult ABI survivors, which I mentioned earlier. But here, and so often in my setting, it evolves much more naturalistically, in a much slower paced and child-led way, but those elements are still very much present. So this next diagram from the identity rehab model shows the adaptation cycle as aspects of the new identity are introduced. So starting at the bottom where it's at motivational participation. In music therapy, we'd established a safe base through the therapeutic relationship, and also our repertoire of personalised music, so grounding and affirming of who he was and who he is, that I can rap really fast, I can sing really well. And this provided a safe starting point for taking on these participatory challenges, either functional, motor tasks or cognitive tasks, or more psychological, thinking about the future return home, for example. So in music therapy, we took on these new tasks, and on the diagram, you can see the bottom left quadrant, we approached a new task where you start to approach, you plan and then monitor new tasks. And we started playing the djembe together. And this is clearly a motor goal, but also the movement task really challenged his former identity of having been a really skilled sportsman. And as you get to the top of the circle in this adaptation cycle, you can see there are warning triangles and alert is highlighted, because a young person can experience really deep sense of shock at not performing tasks that they would have found easy before their injury. And that's where at figure 3, as you go round the circle, you can see there's a real need for reassurance. In music therapy, we could attend to any feelings arising from these challenges. And I could support the young person to understand why things might feel difficult for him. You know, and this alludes to what John was saying about brain injury education. And this is for the young person directly, just little pieces each session. I could show him how we might work on the skill to preserve hope and remind him of how far he's already come. So this takes the young person through that upper right quadrant where it says feel and contain, to the lower right, contain and learn. And so could support the young person at his developmental level to maintain hope and resilience. And then the cycle begins again as you explore new tasks. So, for example, we began a cognitive task of following instructions in a beatboxing tutorial to develop those skills that he had so strongly. So carefully supported tasks help to stop young people from experiencing such a high level of disappointment and distress at that section where we've got the alert. Is such a high, what we don't want is for them to spin off this wheel of the adaptation cycle and disengage from rehabilitation and experience real loss of hope. What we hope for young people is that they can be supported to remain on this adaptation cycle, this sort of virtuous upward spiral of identity, affirmation, exploration and adaptation, which is intertwined with functional skill recovery. Helen Schumacher writes, the supported experience of music may enable the young person to reconfigure their self, and that's what we seek to do here. As part of this cyclical process, we return to the same well-known songs time and again. There seemed to be a real psychological necessity to return to that safe base we'd established. The pattern of the adaptation cycle also brought to mind, for me, the musical structure of rondo form, with the principal theme of that safe base alternating with contrasting sections of forays into the new. So we used our relationship and grounding and affirming music to hold a safe sense of self, while exploring and incorporating more difficult and challenging aspects of the new identity. So just to conclude, from my experience, even when working on very functional neurorehabilitation goals in music therapy, we can do so within a framework of identity rehabilitation that can enhance children and young people's capacity for resilience, supporting them through their losses and challenges, and enabling them to consider in their own unique ways, who was I, who am I, and who can I be?
Thank you, Claire.
Thank you.
Okay, right. Thank you to all our panelists for those wonderful presentations, such a rich and diverse group of presentations. And now I'd like to, well, we've got time for questions. We have about 10 minutes. We've got some questions in the question and answer. And also, I believe one of our delegates is has their hand up as well. So let's go to the question and answers first. If you can put your questions in the question and answers, that will be great. Okay. So let's have a look. So there's a question from Sansan Yap. This is for Becky. Please give more information about the assessment training. And I think Holly Hitchin would also like to know about the assessment training as well.
Hi, thanks for your interest. That's great news. People want to know more about it. We're doing our first training shortly in Ireland for music therapists and psychologists and neuropsychologists in Ireland. And then we're hoping to be able to bring the training to the UK at some point in the near future. It's a 2-day training that have to be taken place by myself, and Sarah will be leading it by us. And you have to be a qualified music therapist and a qualified psychologist or neuropsychologist in order to do it. So watch this space. As soon as we're ready to come over, COVID permitting and everything, we'd be delighted to come and talk to more people about it.
Okay. So we have a question from Katie Richards, and this is regarding neurologic music therapy. So this, I think, is to any one of us or all of us. Do you feel it is necessary to be trained as a neurologic music therapist in order to work in this area? Who would like to? And we could all have a go at answering that, and we may even disagree. Who knows? Would anybody like to answer that?
I'm happy to. I'll just answer quickly. I would say no. I don't think you do have to be. I'm not. But what I have done is attended some training sessions about neurologic music therapy. I'm very interested in it, and I think that there are elements of it that come into the work naturally anyway. So I don't think you have to be trained as one, but there is an interest in it for sure. In the work, yeah.
All right, thank you, Claire. Elizabeth, you had your hand up to answer that as well. What's your opinion about this?
Well, I had a period of being in a neuro rehab without my training and after, so I feel like it's interesting for me to kind of reflect on what I felt it brought for me. I think you can still learn a lot about the principles and the techniques. There's information out there. You can buy the handbook to find out more about it, and certainly like you find with your masters, you come out and you realise now the real learning starts. Doing the course does not mean you now are going to be fully fledged and confident in using all those techniques. It's really about that experience. So I do think that's really important to make that clear. But for me, I think it definitely gave me new ways of thinking about things I might have been doing, new tools, but probably most valuably of all was the clinical language to talk about the work within the MDT in a way I wouldn't have felt confident or familiar with before. So I do think that might be, depending on the setting, that might be something that's worth thinking about. But that's just my 2 cents.
Would anybody else like to add anything? John?
I would. I couldn't agree more. What you said there, Elizabeth, actually. And then just to add for me, what feels most useful, particularly in helping with that language and communicating with my fellow allied health professionals at the hospital, is that sense of the transformational design model. Just that process is really helpful. Being able to step outside of the music and the interaction and then going back into that neurologic music therapy process is really helpful too. And it is, yeah, as you say, it just feels like another way of thinking, another tool in the toolkit. Whether you need it or not, I don't want to judge.
Okay, thank you, John. I think I would probably add that when you learn when you do the training in neurologic music therapy, that doesn't mean you throw away all the other stuff that you've learned. And there's a process of integration that I've noticed that many music therapists go through, of bringing in their core training and adding to that their understanding of the techniques in neurologic music therapy. And there's a lot of knowledge that you get from working within a multidisciplinary team and having to have those conversations with the occupational therapists, your physios, who have all this incredible knowledge in their specific areas. So that's also part of the process. Okay, let's have a look. So I know there are some questions coming up in the chat as well. I'll try and have a look at the chat to see if I can find them. They can get buried a bit though. So there's a question from Evie, Evelyn Mason, and it's for John. Although a chat's just come up, so I can't see it now. It says, she asks, hi John, have you found the education sessions for families have also provided an opportunity to emotionally support the families, or has this support tended to occur in or outside the sessions?
Okay, I'm quite glad you've asked, actually, because I think this is something that now you mentioned I wish I'd had maybe in the presentation, and that's that sense of reasonable hope and trying to maintain a reasonable hope within the education of the brain injury, and it is a bit of a tightrope, and it can be very triggering. It can be quite difficult to communicate very medical, very difficult things, and maybe when you're asking about whether it's in sessions or outside of sessions, I think it's both. We have conversations, we may well, in feeding back reports or assessments or discussions outside of sessions where people are wanting to talk about it. But I think for me, yeah, both is very important, and it definitely opens up conversations to support the family. Sorry, Claire, I think you wanted to say something too.
Yes, I just wanted to chime in that in my recent experience of feeding back from assessments, I would agree with a lot of what you've said, John. Feeding back from a Musica assessment recently, the paediatric version of the Matadoc, the rest of the clinical team really pushed for me to go first, because the clinical information that we had really showed the child. So it was that strengths-based approach that Becky was talking about in the UMPA as well, and it really helped. It was quite a difficult diagnostic, it's quite a difficult outcome to share, but it really brought part of the child. So it goes back to what I was saying about that thread of the person still being there, you know, that identity still being there at the core. So I think the emotional support goes hand in hand often with the brain injury education.
Thanks, Claire. Helen, you have your hand up.
I just
Well, first of all, thank you all. I just wanted to comment on the life cycle that's been going around in my mind about, several of you mentioned the Matadoc, and I know Professor Wendy McGee is on the call. I can see you. And then people have developed, including now, developing the Musica for use with children. And what I was thinking this evening, just listening to you all, was a theoretical models and clinical models developing specifically from your work with children, and whether you now have dialogues with people working in the adult field of neuro rehab, how this cycle works both ways. It's a bit of an open-ended question, so there might not be time, but it's just a thought as to how, you know, how much dialogue you have with people in the other fields, and there might not be time to answer it. That's all. Thank you.
I could just reply to that really quickly, because at the hospital I work 50% with the kids and 50% with adults with ABI. And so I find it's absolutely fascinating how the skills you use with one field you pull upon for the others, and it's very much interwoven, you know, working with children with the assessment and then using the Matadoc and informing to families in both. It's such a huge part, and I think music therapy can contribute so much to that whole feeding back to families, as you all said, in that we've got this rich data with the music that's the positivity in a way, but what you can do with somebody who's had such a complex, profound brain injury, there's so much that can be done with music. And I think that's what we see repeatedly in family meetings when we feed back findings.
Thank you.
Thank you. I'm just mindful of the time. We have a few more questions that it would be lovely to be able to answer them now, if possible. So first question is from Holly Hitchin. Claire, is the model you mentioned available in an article? I think that's the Alison Perkins model that you presented.
There's an article in print which I can share with you or with others when that comes out. I did have some references as well at the end, so if you look at the recording, you'll be able to see the references of what's already been published.
Wonderful, thank you, Claire. And the next question is from Jonathan Tang. This is to Clare. Clare Rosscornes, thank you for sharing your work with that little girl. I'm curious about the cultural aspect, working with someone from a different cultural background. Could you share a little bit more about how you adapted your clinical process or work? Thanks. P.S. I hope I'm asking the right presenter.
You are, yes. Thank you. I think how did I adapt the work? I think the main thing is it's starting from the family's experience. So whether that's the cultural difference or something else. So it's finding out what's important to them. And for this family, it was about their culture. And then I just chatting about the songs that she might sing with Emily at home, or songs that Emily liked. So it just grew from that, really. So then the work then came from that, in the sense of learning a song that they liked, that they sing, and then obviously some English songs they were aware of as well. And the work just grows from that. But I think it's always starting from the family's experience, whatever that is, and the work grows from that. I don't know if that's answered it enough.
Thank you, Claire.
In the time we have.
Yeah. And the last question is from Mandy Pierce. And she asks, this is for Becky, does it have to be a psychologist working alongside the music therapist in the assessment?
Yes, with this particular assessment, 100%, it's for psychologists or neuropsychologists and music therapists. We do also have often, like we did one last week, where we had the OT, the SLT, the parents, this neuropsychologist and myself, and we scored it together afterwards. So the protocol is we do the assessment and then the family and the child leave, and then we score it and watch the video immediately. And we scored it afterwards and they contributed to the scoring. But to actually do the UMPA, it is a psychology and music therapy assessment specifically, even though it does inform the team.
Thank you. I have, if you would indulge me, just one question, and this would be for any of you really. One of the things I'm wondering about, and that I have thought about in the past as well, is the importance of involving family, but then also when involving family, it can sometimes threaten the privacy and the confidentiality of the work. And I'm just wondering about whether any of you have any examples or thoughts about that, about when involving the family is useful, but also it becomes a bit of a tricky issue when, say, for example, you're working with a teenager who would like to keep the sessions more private.
I'll have a shot at answering this one based on a recent experience. Having talked about how with little ones it can be particularly crucial to have family there, I think even with really quite young ones, and this was with a 5-year-old, children can help to indicate what they would prefer. And in this case, I think this little girl really needed to go back to very, very early interactions, and I think she was concerned she'd maybe disappoint her family. So we had a few sessions where we were really going back to nursery type interactions before she said, yes, Mummy, you can come back into the session. And I think it was because she really just needed something comforting, and I think very young children can also still be quite aware of family's expectation. So whereas Mum had anticipated we'd be singing the hits from the musicals and doing maybe more, flamboyant dancing, we were really doing very, very young stuff instead, and we're led by the children and young people always.
Thanks, Claire. John?
Yeah, I was just thinking a bit about that, the impulsivity you can sometimes get with a brain injury. So when you're saying about privacy, and how in some of my sessions when I've been working with maybe some adolescents who've had a brain injury, they can at times become quite impulsive and say things they wouldn't necessarily mean. And it can actually be quite difficult for them to really feel confident within the music and to be spontaneous and to really engage with what we're doing with parents in the room. And okay, yeah, definitely really, really helpful to offer that space and offer that time just to kind of step away to have their individual space. And particularly, I mean, I'm coming from an acute setting, so they don't have much time on their own anyway. So to be able to offer a space where there's a different person, objective viewpoint coming in, a space to kind of just be and to talk is so important.
Okay. All right. Thank you so much to everybody. It's been absolutely wonderful to hear your presentations and to have this discussion with you. We've answered all the questions. I think there was one participant, I think, who had a hand up, but it's not up anymore. Yes, I don't know if is it Zena?
I think they said it was a mistake in the chat.
Oh, okay. Oh, that's fine. Okay. Well, it's been great. Thank you very much to all our panelists, and thank you to Nina for supporting all of us to do this. Okay.
Thank you all for coming. Just to say, there's a survey that will pop up when the webinar closes, so you can give us some feedback, and that will help inform our future events. And our next webinar is coming up on the 25th of April, and that will be a roundtable looking at music therapy and addiction. So we hope to see you then. Thanks very much. And thanks to all our presenters.
Thank you all.
Bye.
Bye.